heartbreak.
So good morning, everyone. Today, we have a real treat today. We have the great privilege of welcoming Dr. Nathalie Maitre to Virtual Rainbow here. Nathalie's been an outstanding researcher and clinician and teacher, and I've had the privilege to work with her as part of the Neonatal Research Network, where she's been a big blessing to mothers, not just other researchers, but mothers struggling to understand cerebral palsy. And as the mom of a child that was born at 26 weeks who's had some motor issues, it's really, really important to me, the work that she's done, because so many times we leave the NICU in the NICU and all the interventions and the innovations there. And Nathalie's really made a career to expand neonatology research into the field of making the lives better for the children and their moms. So a couple housekeeping things I want to mention at the beginning. The webinar is being recorded and it'll be available to be viewed from the UH Research and Education Institute website. And please make sure you mute your microphones throughout the presentation. And if anyone needs technical assistance, just contact the R&E team. Nicole Bollinger and Abigail Zona are on the call. And if you'd like to ask a question, you can type them right into the chat. And you can either put your name, they're going to be seen by all the attendings, or you can submit them anonymously if you prefer. So I'd like to introduce Nathalie. So Dr. Nathalie Maitre is a board-certified neonatologist, and she is the director of the Early Development and Cerebral Palsy Research at Children's Healthcare in Atlanta, and she's professor of pediatrics at Emory University School of Medicine. Her research spans everything from designing parental delivered interventions to clinical trials to, most important to me, implementing these things in the real world to improve the neurodevelopment of our high-risk babies. Throughout her career, she's conducted tons of multidisciplinary research with neuroscientists, gosh, engineers, neonatologists, physical therapists for the NICU infants, mostly aimed at improving their rehabilitation. She's led many NIH funded and even private foundation funded research projects aimed at things like parental driven sensory motor innovations and inventions, and like constraint therapy and bimanual movement therapy and all the things that help the lives of the people affected by cerebral palsy. She's even done things like pacifier activated voice players, which is amazing. She's got tons of robust technology participation from all her collaborators around the world. And she continues today to work with engineers and mathematicians and math modeling teams to develop all kinds of new and innovative methods for brain-based assessments and therapy for these kind of kids. Dr. Maitre is probably one of the best mentors that I know of. Graduate students, undergraduate students, residents, they all love her because she makes the world sort of real for families and for learners. And anybody interested in developing interventions for helping children with cerebral palsy or motor delays or complications of prematurity has learned most of what they know today because of Nathalie Maitre. I can't think of a more awesome person to introduce. So it's my privilege to introduce Dr. Maitre today. She's going to be talking about implementing early detection for cerebral palsy, the national and global experiences. And I'm so grateful that you came to us, Nathalie.
Deanne, I don't think I've ever received such a warm and wonderful introduction, so thank you to you. As you know, and I mentioned earlier to the team on this call, you made me think 20 years ago when my child was born preterm and had CP that I could have it all. The balance of being a mom, a neonatologist, a pediatrician, and still be able to encourage people in this field and make things come true. So thank you to you. And thank you also to Dr. Sam Bora, who has been the most amazing colleague and collaborator I could hope to have. He sometimes says that I'm a mentor, but that's not true. Don't ever listen to him. He is the best colleague anyone could have, and I would have done this for him anytime and any place. So thanks to all. I'm going to share my presentation. Bear with me as I navigate this. I hope everyone can hear me and everyone can see this. If not, please put it in the text box. So this is me. This is what I'm going to talk about. I do need to tell you that a ton of this research has been funded and there are no conflicts in this presentation. So when we think about a diagnosis of cerebral palsy, most of the time we think of this definition that was from 2007 by Dr. Peter Rosenbaum, a disorder of movement and sensation that causes activity limitations attributed to non-progressive disturbances originating in the perinatal period. So for neonatologists, that's us. For pediatricians in the community, that's, anything in the perinatal period before birth and after birth. So what this actually means in practice is very different from the theory and from what our expert neurology colleagues might consider. What it means is to make a diagnosis, we need certain elements, a neurological exam, some motor function assessments, neuroimaging, biomarkers. And by biomarkers, I mean, just like for other disorders, when we have scores or readings on a pattern that tell us that someone is at risk. These are biomarkers and they can help us predict risk. And then we do need to rule out progressive disorders. So with all of that, how does that translate into practice? Not well, it turns out. And that's why we need to think through early detection. How do we detect early and not at an average age of anywhere from 2 years to some countries 4 years? So I always think about the Golden Circle by Simon Sinek, which is we should start by why should we do this? Why should we detect anything early? There are 2 really good reasons: parents and interventions. So we're going to talk about both. The first is parents.
I've got a daughter who's a year and a half now, and we received our CP diagnosis when we were 8 months old. And the entire time we knew that she had potential to have CP, but we were always told it was going to be, we wouldn't be diagnosed until we were 2. We wouldn't be diagnosed until we were 2. So when we got our diagnosis at 8 months, it was kind of, it was earth shattering to me, because even though I was expecting it, I was just waiting for this magical number of 2 before they actually said, your daughter has cerebral palsy. This is what your life looks like. So I think when we got that early diagnosis, it helped. We were relieved after it sunk in that this is what our life is. But I wouldn't continue to tell people that 2 is this golden number. You're not going to hear anything until 2. We'll wait and see how they develop. If you know, then tell us now so we can plan our lives and try to make the best we can for our children.
So that's Peyton's mom. And that's just one parent, but there's research to support this. We know that delays in diagnosis of CP are associated with higher levels of dissatisfaction and mental health problems. We also know that the time between when suspicions arrives and when identification is made is so stressful for parents, and it absolutely should be minimized, because what happens is a distrust of the entire healthcare system, not just the person not telling them, but all sorts of other people who are going to need to help them navigate their journey for the rest of their child's childhood, but also transition into adulthood. So we also know that parents want an honest, hopeful, and direct message. 3 principles that they have told us time and time again, and they are very accepting of what we call a high risk for CP classification or designation, meaning if we don't know, it's still okay to start talking about that word and to say, we could be wrong, it could be something else, but this is what we're thinking right now. Why is it important also? Because the spectrum and scope of early problems in CP starts very early. And if we know that there's a high risk for CP, we can start looking at problems that we can intervene in the first year of life, We can additionally screen for these. In the second year of life, we can make a difference to some terrible comorbidities, such as pain, for example, and hip displacement. That's when it starts, sleep, feeding. And then in the third year, we can start to make a difference to other issues. So detecting early also means addressing comorbidities earlier. We also know that there are targeted interventions for the under 2 with CP, and these were published in JAMA Peds in, I believe, 2022. And they are specific sometimes, or sometimes best second line intervention for various domains. In addition to this, several systematic reviews have looked at assessments and intervention for sleep, spasticity, pain, and hearing in CP. And they all point to the fact that diagnosing before the age of 2 does not mean watching and waiting or just referring to generic early intervention. It means choosing pathways and interventions that are specific to CP. Steve Roach, who's the editor of Pediatric Neurology, or who was in 2021, said it fairly well here. He said that the notion that CP can't be studied in infants is utter nonsense. And he was talking about some systematic reviews that were published, and they said they clearly define a baseline state of affairs that is no longer acceptable. And so we need to improve it. And for that, most of what I'm going to talk to you is about improvement science and implementation, and not simply about new research. New research serves very little if it is not implemented into practice. So I'm trying to move forward. I apologize, and my slide is stuck. There we go. Let's talk about how. I just told you how we implement early detection, why we should implement early detection for CP. So let's talk about how. I know we are privileged enough to have people from different places in the US, but also from different parts of the world. Most of what I'm going to talk about in implementation and what happens next is in the US, but I do want to tell you that I will talk about implementation and global considerations in our work in this area as well. So, how? Implementation science, use of and development of tools and practice instead of just research, and use of guidelines can all help translate early detection from a why it should be done to how it should be done. To start with this, we're going to start with this paper published in 2017, which was international consensus guidelines that were done by, as you can see, a huge group of stakeholders across the world that talked about early accurate diagnosis primarily, not so much intervention in cerebral palsy. These guidelines were based on a systematic review of systematic reviews of evidence to identify pathways and tools for detection. They were performed not just by a group of multidisciplinary experts across various health disciplines, but also researchers. And parent and community stakeholders were included as part of this group to make sure that this was not just something that was done from a research perspective, but also from a stakeholder perspective. What they all came to is this conclusion: early detection should occur because it allows optimal developmental trajectories for children and best outcomes for parents. When we deal with young children, we're dealing with the dyad of the family and the child, which is actually the most important one above the ones that parents might form, for example, with therapists or physicians. This paper identified two primary types of patients that were at risk or could develop cerebral palsy. Those that had newborn detectable risks, which most neonatologists take care of, and these are preterm, and those with encephalopathy, those with a known history of neurological risks, such as birth defects and IUGR, but also more recently intrauterine drug exposure, and parent-identified concerns. All of those can happen, and we can see them in the NICU and in NICU follow-up. However, there's another group that is primarily seen by outpatient care providers or by NICU follow-up clinics who tend to function as safety nets for those areas that have perinatal regionalization grants, or simply because no one else will see them. Those are children who have parent-identified concerns in the first year, delayed gross motor milestones, early hand preference, and Zach Boychuk has done a fabulous job of looking at some of the signs in the first year. There are standardized elements for detection, and while I'm primarily going to talk about those less than 5 months, there are some that are above 5 months. In green in this figure, what you can see are those that have the very highest level of evidence, lots of either research or systematic reviews of high quality. And in orange, the ones that are the next best level of evidence, although I will tell you, some of those have changed since this paper was published. Some of them have perhaps been downgraded a tiny bit, like the TIMP. Some of them may be upgraded in combination, such as the Hein and the Ames. And so this is, and some of them may be upgraded as well in pathway B, which is if you don't have access to high resource tools like in pathway A, go to pathway B. I'll talk a lot about these because the Hein and the DAISY have really helped us transform how we detect cerebral palsy early in places like Uganda, Peru, and Bulgaria. So here we see in the early pathway what these look like: Hein, MRI, and general movements, and the DAISY. Now, I've talked to you about this guideline paper and research paper, but how it then translates from guidelines to actually practice, no one had done. So what our team decided to do is leverage one of the best known and most flexible frameworks from the National Implementation Research Network, which is called Active Implementation Frameworks. And this framework has 4 stages, the first being exploration, during which we understand our system and study its feasibility of implementation, then an installation phase during which we ensure team and system readiness, followed by an early implementation phase, which has limited scope that allows us to obtain quick feedback on what we do with some quick, hopefully, successes to make sure that we continue. And finally, full implementation, which has a slightly larger scope and necessitates continuous improvement cycles. For neonatologists who are so used to quality improvement, a lot of the PDSA cycles fit somewhere between installation and early implementation, and PDSA cycles can actually be used as part of active implementation frameworks. So how did we go from these guidelines and then approach this implementation framework? First, we had to translate research, which was lots of research papers, but not a whole lot of applied ones, and build capacity. So we had to develop skills workshops because a lot of these assessments, such as the Hein, only existed in research and neurologists, and no one had ever bothered to translate them to something that anyone could do, and especially our allied health providers that are so critical to our multidisciplinary teams in CP, such as physical and occupational therapists. So those needed to happen. We needed to develop checklists. I'm a huge fan of Atul Gawande's The Checklist Manifesto, and CP is full of complex processes and conversations that carry risk of forgetting something or missing something. So checklists were really important. We had to train teams with their communities, and these were some of the considerations that were not mentioned in guidelines. If we were going to start with NICU follow-up on its own isn't worth anything without the community of early intervention providers and our critical partners, primary care pediatricians. We had to figure out how to teach implementation. We take it for granted sometimes as people working in academic centers that everyone knows how to do implementation. However, I will tell you, and I've told Sam this, it is very humbling to realize when you first start that your experience in QI does not necessarily prepare you for implementation science, and that you have a lot to learn, usually through mistakes, and then you go back to the drawing board and you learn more and you take courses and you improve. And finally, we needed to nurture an improvement culture of transparency, change management, and other things, which in this field, in the NICU, again, we take it for granted, but it's not so much the case everywhere in the community and in the outpatient world. It's not always the case without access to a major academic center. So how did we do this? First, we designed a Hein workshop because the Hein, the Hammersmith Infant Neurological Exam, needed to be turned into a tool transmitted from very few neurologists to another very few neurologists in a way that was slightly informal to a way that was a skills building workshop for anyone. It had to be implemented. I made a lot of mistakes during that time and tried to learn from them. Then we had to implement the whole set of guidelines, remember early implementation, in a single high-risk infant follow-up program to learn enough lessons from those exploration, installation, and early implementation phases that we could consider a full-scale implementation that would be real implementation across a network. And that's what we did in the US in about 2020 with the help of the Cerebral Palsy Foundation that really helped us engage people in the most unorthodox ways, sometimes sitting underneath posters at conferences thinking, are you interested in this? And then finally, in the last few years, scaling up internationally, but mainly adapting, and I'll talk about that. The tools we used, because active implementation frameworks is so flexible, we leveraged a lot of Lean and Six Sigma tools such as these, but also process flows and value-added analyses and all sorts of tools that are more part of the business world. We used what many of you know is Institute for Healthcare QI methodology and PDSA cycles, as well as things that we borrowed, strategies that we borrowed from IT, agile strategies that allowed us to plan sprints and really collaborate, adapt, and change quickly that were outside traditional waterfall project planning. So the first experience in the US was across this network, and our goal was simply to implement the guidelines I showed you from 2017 across a network. And our primary aim was simply this. We knew that we needed to decrease our average age at diagnosis from around 2 years to what we were hoping for was 12 months by 9 months after the installation phase of our project. Our secondary aim, which was one of our actually main drivers, was to increase the number of 3 to 4 month visits with those critical detection elements by at least 50%, because we knew that 3 to 4 month visits, 3 to 4 month corrected age visits, for those of you who see preemies, would be critical to moving this forward. We needed to have balancing measures to see how we were affecting our system. Because we deal in high-risk infant follow-up, which has very high no-show rates, we needed to know how we were going to impact those with complex processes and how parents were going to perceive these diagnoses. And finally, we wanted to collect data on parent affect and their ways of coping to sort of plan how we could improve how we gave diagnoses in our next phases. So our detection network was pretty huge and incredibly diverse, from urban to rural, from places where there were, there's a vast sociodemographic mix. And this is how we first started. Where you see the large catchment area in pink is because Utah's catchment area for the University of Utah is enormous. They have to cover parts of Colorado, Wyoming, and I believe that's Idaho. I think so. My US geography is clearly not what it should be. So we had to consider also what is the context for discussions of CP and HRCP and NICU follow-up. This is more recent information that we have, but you have to understand when we were trying to give these diagnoses, our population was already in a state of trauma. And many of you now are very much aware of trauma-informed care, and you're practicing it, and it's wonderful. But at the time, it wasn't the case. What we do know is that a ton of our patients screen positive in our clinics for depression, post-traumatic stress disorder, adverse childhood experiences, and whether these are children that are already in the follow-up clinic or matched to those receiving a diagnosis of CP or conversation of HRCP, what we know is that they're not different. They're still facing all of these things. This is the work of Dr. Salathiel Kendrick Allwood. We also know that they have a tremendous amount of unmet social needs, such as income instability, housing insecurity, food problems and access to care. And you can see that they are missing so much. So in this context, we had to give diagnoses of CP, and this is what ended up happening. First, we were able to decrease over the course of those 9 months. What it turns out, our weighted average age at diagnosis was about 19 and a half months corrected age, and we brought it down by the end of 9 months to about 9.5 months corrected age. So that was great. But what's better is to know that the reason we were doing that is that we had met our target of increasing those 3 to 4 month visits with all those elements. And you can see that our high risk for CP classifications had increased proportionally with our new diagnoses. So great, it worked to implement it, but what else did it tell us? It told us that we needed to do a lot of improvement cycles, because what we got from this implementation is that there were problems with the information that parents needed, the follow-through they were getting, the future thinking and goal setting that we needed to do with them at the time of diagnosis, their need for social connection, their need for mental health supports, and their need for wraparound care and care navigation. So you can see that all of these are what came out of development opportunities from that early implementation across these sites. And all of these became continuous improvement cycles across the network in various ways. What also happened is that we understood a little bit more about the high risk for CP classification, and that it needed to be more formalized. For that, we relied on our network of NICU follow-up providers in the US, but also our team in Canada, our counterparts in Canada. And we got together, all of us, and we said, we are all going to say that we are going to give a high risk for CP clinical designation, because here are the guiding principles that we have for giving this: respect for persons, beneficence, justice, and equity. For those of you who work either in research or in DEI, you know how important these concepts are. The purpose of this was to really start across our entire continent using a common language, and to start joint decision-making and goal-setting conversations. It was not because we thought giving a high risk for CP designation was a way to face our own fears and delay a diagnosis. And there are two clearly defined situations. Since then, the wonderful Faith Kim, who works in Columbia, has published on this extensively, both in NEO reviews and in the Journal of Pediatrics Grand Rounds case reviews, to really show how high risk for CP works. This is the list that she published in Neo Reviews, a checklist, which helps not only when we see babies to go through this really challenging time, but codifies the two situations and how to convert from HRCP to CP. So how did this evolve? Well, over time, we managed to, with those continuous improvement cycle, achieve change and sustain it over these years, even as the network grew with new sites and lost some. But now it includes 8 sites and is continuously adding more. Despite adding new sites, the process, the implementation toolkits that were set worked consistently. And you can see that even though the network grew far beyond its initial size and added new sites and went through COVID, this continuously worked. Now, let's qualify the COVID part because you can actually see the blip in the age at diagnosis that happened in 2020 when we increased to 14.2 months. And that was because we all felt really uncomfortable making initial diagnoses simply over telehealth. And it delayed everything from high risk for CP age to age at diagnosis. So we can sustain this, we know it works, and we can keep improving. So what comes next? What comes next is starting to see how could we bring it down lower? Could we even? What about our diagnoses practices? What could we do better? So here you can see what it looks like across the network over quarters and years of doing this, about the proportion of children who get a diagnosis without prior HRCP determination or those with. In dark is the without. Those children, two things are happening. They're the ones that we know earlier on are going to have severe CP, and we know right away. And they're also the ones that the providers in our network who've been using the tools that I mentioned to you have become really familiar with and can diagnose right away. Then you see the ones who need that HRCP, and a lot of those tend to be the ones that have the mild diplegias, the one who presents with toe walking at 2 years when it seemed everything was going okay. But now we're able to catch those earlier because we use HRCP and we're following them in different ways with different tools, such as tools to examine selective motor control or gait emergence. Also, over time, we were able to look at parent ways of coping. This was a study of over 100 parents who were studied 3 months after they got their diagnosis in our network to examine, in the US at least, what is the way that parents have of coping with a new diagnosis. And we found some surprising things that are not totally consistent with some other circumstances or diagnoses such as cancer. What we found is that you'll see on the left, this is the predominant coping types, an explanation of what that psychological concept means. And on the right, it tells you the mean for that particular category. So I've bolded the ones that are the predominant ways that US parents had of coping with the diagnosis, as opposed to the others. Accepting responsibility, which was really informative for neonatologists, was predominantly the way of coping. And this means neonatologists can make a difference, because what we can do starting in the NICU is making sure that these parents understand that there's nothing that they were responsible for, and that we can unburden them of the trauma and the guilt. And that needs to start in the NICU, and so that they are better prepared to make efforts to overcome what their child is going to face. So even if you're not diagnosing in the NICU, we are counting on every neonatologist out there to make sure after an IVH, after HIE, after stroke, after PVL, after a change in brain imaging that might happen because of NEC or BPD, or a cram synchronized general movements, be there to make sure that those families hear from their neonatologists that there was nothing they could have done to change this, and they are not responsible. The other things that they have that are positive are planful problem solving, positive reappraisal, and seeking social supports. These also inform how we can better help parents with coping. Reassuringly, some of the negative behaviors, such as confrontive coping and escape avoidance, are actually towards the bottom of these. We did change counseling in this network over time with parent feedback. And these are some of the results. Again, these were over 150 parents that simply we surveyed about the time of the diagnosis, and they rated their providers. And you can see that overall, there was a lot of positive, but there was also some not at all. Imagine being a parent who received a diagnosis and thinking that their provider did not show they cared about your feelings. Even though it's a tiny bit, we immediately went into why a root cause analysis as to why this could happen. And then information about the diagnosis. That should never happen, that we should not have enough information, especially in words that they could understand. And then one thing we are good as physicians is always making sure that we ask if there are any questions that parents have before they leave. So based on all of these things that I'm telling you, we devised workshops that were informed by stakeholders and psychologists, but that went through continuous cycles of feedback from our providers and our parents. And all providers in the networks are now trained in standardized workshops with demonstration and really uncomfortable role playing. There's education on parent perspectives surrounding early CP and shared decision making. And the other thing that happens is that there's training that's promoted with observation and practice, supported practice, where we recommend that people such as masters in social work, who are the best people to support parents during these diagnoses. I think our social workers are so key to this process. They actually provide feedback to providers on an ongoing basis, so that we can always be improving the way we do this. The other thing is we provide parents with roadmaps of care at diagnosis, and sometimes if they need more processing time at the second visit. And during these roadmaps, we address all aspects of the International Classification of Function, so the ICF. We look at communication, thinking, learning, sensation, but also movement, muscles and bones, nerves and pains. For those of you who know the ICF, we give roadmaps. And so that parents have for that year a list of all the things that they will do to navigate the year ahead through interventions and support, some of these clinical trials, some of these community resources, but they are not alone. They will navigate that road ahead, but they will not be alone. We will be there to offer sometimes signposts and sometimes just a hand to hold. So now what? We need to do more scaling up, more adaptation, and more research. And this is what I can show you. Early detection and stakeholder engagement does lead to more early intervention research. You can see here in this map in the US, as of a year ago, what all these associated QI collaboratives that currently exist across, for example, Texas and New Mexico, Yvette Johnson. And, some of the people in New Mexico have managed to pass legislature now for early detection to be part of New Mexico's mandate in EI. Network catchment states, and then the UCP, United Cerebral Palsy Network, which is private EI in the community that have also joined in these things. So we're starting to impact all of the US. And I just talked to the amazing Sarah Netches and Lisa Letskis, who are in Virginia and in the state of Washington, and they are also doing it there. So this map is expanding all the time. And why is it important? Because early detection and it also leads to research and early interventions. These are just some of the multi-center trials that involved all these states. And you can see that the map is changing. Sometimes it's through interventions that are NIH funded, some PCORI, and some that are foundation funded. And I'm sure there are more that I haven't put on this map, but the map of the US is changing for early intervention as well. Early detection drives early intervention. Just like in neonatology, if we didn't start resuscitating 22 and 23 weekers, which, by the way, when I was a fellow, we didn't, um, we wouldn't have some of the ways of caring for them that we do now in neonatology. By pushing the boundaries to earlier, we are also pushing interventions to earlier. So the other thing we need to do based on some of this work is adapt to scale and consolidate. To do that, we need to culturally adapt our toolkits and expand and modify networks of change. And I'll talk to you a little bit about some of that. We need to develop and implement new interventions. Um, we need to map and drive lifespan changes after the early years. We need to build educational pathways and standardize the certification of these programs. And we need to have advocacy and policy both in national and global stakeholder partners. So I can tell you some of the state level efforts that we've done in Georgia to shift state policies and family supports. What we do is we work with state EI and the Department of Health and Behavioral Health to have win-win situations that help us provide better EI and better detection. We can transform healthcare systems and high-risk infant follow-up networks by supporting both pediatricians in the community and working with payers. We focus on underserved communities in Georgia. There's a large rural population and a lot of socioeconomic disparities. So focusing on those population really helps us get not just the babies from the NICU and make sure they come back, but also the babies from that other pathway, the newborn attributable risk. We leverage existing federal and state mandates, especially educational ones or some of the IDEA Part C mandates. And then we try to work on a systemic integration of research through stakeholder engagement. I'll talk to you a tiny bit about that. So some of those big ideas that I'm talking to you about have resulted in tangible successes. The buy-in that we've obtained means that we partner with these institutions from the AAP to community CP organization to the Georgia Departments of Health in either educating or building new standards or working with pediatrician networks in terms of screening and referrals. We also completed 360 degrees needs assessment, but of stakeholders across from educators to clinicians to researchers to obviously parents, children, and adults with CP to figure out what their clinical care and their research priorities were. We built resources for the 0 to 5 to make sure that when we provide resources in high-risk infant follow-up, we have a map for allied health and social supports that targets to where a patient's family is. 100%, obviously, it's most of you do this as well. 100% screening for social determinants of health and mental health in high-risk infant follow-up and resource provision based on these maps. And then finally, implementing early detection guideline in every state early high-risk intervention program, meaning it's not enough to be in a big academic center in Atlanta. We went to every single perinatal region across the state and trained each and every one of them in that detection. We developed toolkits for primary care and built those connections with them. And now what we're working with is the dean at Mercer, which is one of our rural medical schools, to make sure that we are training rural family medicine and pediatricians through these pathways at the level of medical school. And finally, we're working on state funding, which we've received to attend state CP conferences, but as a parent clinician dyad. So the parents get to bring their OT, their PT, their neonatologist to these early CP conferences, and they go as a dyad so that both of them get to benefit and spread their knowledge. We also have community summer camps that the state has funded. So global efforts briefly, and I didn't want to, this is what the map of the world looks like for early detection of CP. The darker it is, the better established and widespread it is. So the US is doing pretty well. At least for clinically, the US and Canada actually started clinical implementation before Australia did. Australia's in green, but they started with research rather than that, but they've caught up. And you can see that it's spreading throughout Europe. We had to develop toolkits that would work for our UNICEF partners in Uganda, Peru, and Bulgaria with key tools and detection workshops that are these that you see here. But every time the counseling is based and they reflect local parent testimonials. This morning I was on with a parent from Malawi, and it was just heartrending to hear her talk about what early diagnosis of CP was. We also, not forgetting our lessons and how bad I was at implementation when I first started, make sure that we teach them the basics of implementation that they can do. We have culturally adapted storybooks that can be used using simply pictures and oral tradition, which is really important for countries where the word CP doesn't exist. In Uganda, they call it an attack on the brain. We don't want to use that word, but we still need to convey what's going on to parents. And then we've developed new workshops on best evidence early interventions that we've now piloted in Uganda, Peru, and Bulgaria for upper extremity and gross motor that are specifically adapted to settings in which resources are sparse. So last, we did this in Ireland, and Ireland, whoops, that didn't work the way I wanted it to, but we are now implementing it across all of Ireland, and Ireland is actually about half the size of Georgia, but the healthcare system is so different. We started with some of the high-risk infant follow-up programs that you see in the big dots, and now in level 3s, before even going to level 4s, and we're going to have to spread to the community and level 2 NICUs and also community practices. So early detection is spreading throughout Ireland as well, using a slightly different toolkit that was used for the US. And so, you know, between our partners with UNICEF and those in Ireland, we hope that soon the whole world gets there. And I just want to say a quick thank you to my lab at these amazing summer camps and all the parents and families that help us participate, and mostly all of our students and trainees who are what this is all about. They're the ones who are actually going to change the world, and it's their passion that I want to foster. So thank you.
Thank you so much, Natalie. That's an awesome presentation. I was going to say that I believe people sometimes undergo trials so that they're refined in order to serve as gifts to other people. And I believe that you've come through some trials to be refined and are an amazing gift to other people. And I so appreciate that. We're going to open up the chat room to questions. I have a question right off the bat. I was wondering if you guys struggle with this. This is something that's come up new for us in Ohio. So we're based on your work, we know that it's really important to get early recognition. And so we've made a big effort at our center to try to identify kids early and to send out early intervention teams early on. But we've sort of confronted a new problem. When the teams go out and the kids have risk, but they show up initially normal, then what happens is they get discharged and everyone says, oh, they're fine. They don't need to be followed anymore. And I was wondering if you've seen that and what we could do about that.
Yeah, so that's a huge problem, right? Because the state resources are so limited that a lot of what they do is they have screeners that are designed just to get the worst of the worst, right? So that we don't miss those, but not to waste resources that are so sparse. So I agree. What we do is we combine early detection with parent education. And so we've developed some telehealth interventions, and Sam actually knows about some of those
That's a good idea.
that bridge the time between high risk for CP and some of the things that will really qualify them to support parents, at least in their child's motor delay, but more importantly, have a wraparound approach to try to build their knowledge surrounding this and their ability to partner with their OTs and PTs. And we're still in the early phases of that, but we have some good evidence that this works. And so any parent support intervention that you could do, even if before the child qualifies for services, you want to not have the parents lost, I would enroll them in a parent support program, whether it's triple P or something else, so that they actually feel empowered to do something and change what's happening with their child. I think the frustration for them is even if OT or PT were to start, it's not necessarily going to be one that's targeted for CP. And we can talk about that. The CPF organizes an annual conference with skills workshops that work for teaching interventions in the 0 to 3. So we also need to build capacity in EI, which in Ohio is a huge deal.
That's a really good idea. Really good idea. There's a question in the room here from the people that are with me. Neuroimaging has gotten a lot better at predictive abilities as well. And we've had some bantering around about how big should neuroimaging be, fancy neuroimaging like MRI. Should it be part of our regular care, or should it be offered only in certain circumstances? What's your thoughts on that?
So that's really interesting because you have on this call who you can see someone who's just published a couple papers about that, and so
Yes.
he probably answer that. But what I will tell you is I do think what we've shown across the network is that using the GMA to help guide neuroimaging beyond simply doing it. So it's always been counterintuitive to me in neonatology. If we know someone has a grade 3 or a grade 4 or cystic PVL on ultrasound, then clearly their MRI is going to be abnormal, right? So is that actually going to help us diagnose anything? Is it going to change our plan? Not so much. It's the ones who are at the borderline, right, that we need to look at, the ones that we're not sure about. We know that grade 2 is not a great sign. We know that inflammation can change the microstructure of the brain. And just because someone had a flare or something else early on doesn't mean they won't later have a problem. So I think using the GMA at writhing age, which is in the NICU, maybe around 34 to 36 weeks before a child goes home, and when you can do an MRI, we actually published on that, can really help catch the abnormalities on MRI that you would not otherwise with a normal head ultrasound or a grade 1 or 2, or even no head ultrasound in some babies. So I think universal GMA could help target that so that you are still responsibly using your MRI. And then I think AI is helping us with algorithms that can help guide who would best need neuroimaging before they leave the NICU to try to detect some of these other problems. But I want to talk about something that Joe Volpe talks about this all the time. He has two posts in the Newborn Brain Society about the fact that dysmaturity of prematurity and dysmaturity of after neonatal encephalopathy create problems that are not always visible on MRI. Do not be fooled by a normal MRI. Remember that in CP, at least 17% of children who really have obvious CP, spastic CP, I'm not talking hypotonic, 17% of them have normal MRIs. It does make it easier when our partners in the NICU don't use MRI systematically, but use it wisely. And I think GMA is one way to do that. And like I said, I really think with new AI algorithms, We're going to use perhaps EEG, which is quick and fast, to help guide some of that, and combined with clinical factors to help guide. Not everyone needs an MRI. That's a waste of resources, but certainly more children and different children than are currently getting MRIs need them.
Excellent, excellent. Another question from our room here. My group here is real familiar with DCD because of the work that we do. Do you think we'll ever get to the point where all these minor, quote, minor neuromotor problems will also qualify for interventions as well? Because they can have some pretty big life impacting things as well.
Yeah, I see it. So DCD is a really interesting question, Dee. I think that part of DCD is actually CP.
Yeah, I agree.
And so I think when we think about the definitions surrounding DCD, there really can't be any neurological impairment. If you've got spasticity at your ankles, it's not DCD.
Exactly,
It's
exactly.
mild CP. So I think
Exactly.
a lot of it is the tools we use and the language we use. I do think two things are going to happen. DCD is going to be recognized as something else, because right now it's sort of this
Uh-huh.
bag, like put it all in that, because we
Uh-huh.
don't really know what it is.
Uh-huh.
And the other thing is, I do think as our neuroimaging improves, and as we work on other algorithms of, like I said, incorporating perhaps EEG, other biomarkers that we can use in the NICU, then we might find, and as whole exome sequencing becomes better and more rapid and more available, that a lot of these things are going to be earlier on detected as something else.
Excellent, excellent. Another question from Dr. Bearer: is anyone looking at nutrition in these kids? This is a great question. Choline supplementation in the fetal alcohol kids has improved their outcomes, and she was wondering, is there a role for it in other causes of brain injury as well?
So there are some people looking at this. In the UK, they've done some amazing stuff. I think that not enough. I will tell you that right now we have a huge problem, Dr. Bear. We don't even have growth curves for 0 to 2 with CP. Our growth curves in CP start at 2 years of age. So we don't even know, in terms of nutrition, what we could be doing in those first 2 years. It's a big black box. We have some ideas of what happens later in terms of what the muscle infiltration with fat, for example. Could there be some nutritional interventions that would help with some of the osteoporosis, some of that muscle infiltration, and the very fiber of these spastic muscles or hypotonic muscles that are being formed? There's not enough known, but it all starts with growth. If someone would just publish some fabulous growth curves for kids with CP, and even in the US, start here, I would just be thrilled. So not enough is known. There is some thought, though, in nutrition that there is a role for antioxidants and for some basic antioxidants directly into the brain, and others which have to do with omega-3 supplementation. There's some intriguing nutritional things there.
Great, great. Dr. Bora has another question.
Thanks, Natalie. This is great. Just a quick question. You mentioned about telehealth, and again, I always think about, can we reach via telehealth families who might need these interventions the most? Means, how does telehealth and equity kind of come together?
Yeah, so I think telehealth, you would think, would be a way to promote equity, right? But it's a double-edged sword, as we found out during COVID. There are still plenty of people who don't have access to both the technology and the internet availability. I work with people in the mountains of North Carolina right now. We're helping set up a huge program of high-risk infant follow-up there. And the only way for them to get internet is to have satellite, and which is expensive, right? But we try to come up with practical solutions, and I know you're very familiar with those, which is, can we leverage libraries? Can we leverage the Walmart parking lot or the McDonald's parking lot? And can we, we've done a lot of creative things. So can telehealth help? Yes. We do have to validate some of these tools. Right now, our team is working through an NIH grant on validating the hind via telehealth. It's not validated as a neurological exam when the parent is performing it. So we have, beyond issues of equity, we also have issues of, we still have not validated our tools for telehealth. We assumed that everything we did in person would work via telehealth, and it's not. And then the last thing is mHealth is beyond just telehealth. It's like, how can we leverage mobile health, and how, so apps, which are really cool as well. And, I'm very interested in social networks, and how can we leverage social connection, which our parents have told us what they so badly want, to not be a source of disinformation and, we're just going to call it cognitive dissonance. How can we instead leverage social media and social connection to instead do interventions and detection and parent support that is truthful and honest with all its limits?
Great answer. Jocelyn would like to know, is the checklist for diagnosis and for high-risk CP that you presented the one you're using as a tool to confirm cerebral palsy? And what kind of supports you have in place for kids that have CP?
Yeah, so that list is something that's very useful for some of our providers who are not as familiar. Some of our APNs who work with us really enjoy having that list. However, when we put the list in place and we implement, we always have a buddy system, meaning if someone is uncomfortable, there's always a backup call. So that if someone is faced with the list and is trying to diagnose, knows all the elements, there's always the call a friend, meaning you can call a more advanced provider and get them either on FaceTime or on the phone to either guide you through it or participate in the room with that, so that someone who's new or unfamiliar, or let's face it, in a really complicated situation sometimes, isn't faced with that all alone. We found that over time, they need it less and less, but there are some situations such as parents who are angry, parents who just are having problems with trauma, where they need us to support them more, even if they become experienced. Having our social worker to support, again, I cannot say enough things about social workers. They are some of the most key partners in any challenging developmental diagnoses, because they are going to do that follow-up phone call that happens. And that's, you asked what we do. We don't just provide information. We have a postcard from the Cerebral Palsy Foundation that has a QR code. We've integrated it into our Epic, and it literally says, go to this site, cpresource.org, but promise us you're not going to look beyond the early years, because by the time your child is 5, the whole landscape will have changed. We know now we have interventions that did not exist 5 years ago. And I will tell you one of those, neural sleeves. We have children walking with neural sleeves that were not available. They were at their very infancy of gait stimulators. And now you can have a young person with CP hiking the mountains, somewhere with these neural sleeves when they couldn't walk before. So the world is different. There is hope. And some of what we have at that time is not just this checklist, support and counseling, but it's also, we're constantly looking to see what is new and what is the hope we can give in a very tangible way.
Nathalie, thank you so much. Those are awesome answers. Thank you for being such a blessing to the families and to the research community, and truly figuring out and teaching us how to make lemonade out of lemons. And we really appreciate your talk. Was awesome. And it's a true honor to work with you.
Thanks, Steve, but they're not lemons.
And thank you all for today for your participation.
Thank you.
Thanks. Mhm.